Hello, everybody. Ooh, small class today. Over. Oh, please. Now, even now, stop it. All right. Barring further interruptions, let's begin. Hello, morning. All right. So today, and I don't feel better, by the way. Thank you for asking. So I'm gonna do my best. Luckily, we're gonna go over what's wrong with me during today's lecture. So today we are going to go over part 2, the second slideshow, which is the disorders of the respiratory system. So I will share these. Somebody asked me last class, do we need to know the disorders? And I think I said, kind of. Or maybe it was an email or something. The answer is no, all the ones on the slideshow. So, but luckily, the cool thing about the respiratory system is if you know what it's supposed to do, then disorders are super easy, okay? So, let's see. Am I sharing? I'm sharing, right? I think I'm sharing. Am I sharing? Or not sharing? Can y'all hear me? Yes. Yes, you can hear me? Yes, I'm sharing? Okay.
Yes.
You see,
Awesome. Sweet. Okay. All right, let's talk about disorders of the respiratory system. So, sorry. Let's do that. Okay, so let's talk about like a list of things that you should kind of know all of these terms, okay? When you're studying for a test, you don't have to go like really deep into the pathophysiology and all that crap. Just know like what is wrong in each of these things, okay? So, and we're gonna go over that a little bit. I might go a little further in depth, but just know like as far as test question goes, like basics, okay? Don't sweat too much about these. Just kind of know the basics of these, okay? These terms over here on the right and this one right here, these are mostly imaging terms. So at some point, I'm going to cut out of this slideshow and I'm going to show you another slideshow, which is not going to be, what's the word I'm looking for? It's not going to be something that I would say is like necessary. for you. It's just going to be ancillary knowledge. So I'm not going to like present it as material for the course, but I'll give you the website and tell you you can play around here if you'd like to learn more. Okay, because I'm going to teach a little bit off of one of the slides that I have from that. Okay, so don't worry too much about that. But just know it's going to be more like helpful for you. Okay. All right. Let me make sure I have it pulled up real quick. Yes, not the animations. Hold please. Basic principles. Yes, but where is the slides? I just pulled it. Okay, hang on 1 second. I gotta pull these up again. Okay, bear with me. Technical difficulties. This is the PowerPoint. No. Hang on 1 second. I gotta pull this back up. Where was it? Lecture slides. Here we go. Okay, let's try this one. This is it. Think. Hang on. They all have this crazy background, so and you'll see it in just a second. But this is not it. Okay, hang on. Sorry. Intro. Where's the actual? Okay, I don't need the slides, but I can teach off of what is in here. Okay, so I don't know what happened to the slides. They just disappeared there. Luckily there's a website, so I'll just show you what was on the website and on the slides. Okay, cool. All right, so let's talk about respiratory disorders. Okay, so these are like diseases that you can have, right? And then these are like problems that you can see. Okay, pneumonia is a disease, but it's also like a problem thing. Hypoxia, and then lung cancer is obviously a disease. It's not like a problem thing. So let's go through those. Just as a normal recap, a normal lung is secreting mucus and surfactant. It's supposed to be flexible and spongy. The gas exchange happens due to small changes in pressure gradients. And if all of that goes normal, you should be able to breathe normally. Okay. And it's all mediated by the diaphragm. Okay. So just keep that in mind as we get started, and then these diseases will kind of pick out little problems along the way. Okay. So COPD. So COPD is a progressive disease. There's different stages of COPD. It stands for chronic obstructive pulmonary disease. And the big hint on what COPD does is the obstructive pulmonary disease. Okay, the obstructive part. So there's two things that was four. There's two things that cause problems with COPD, and that is bronchitis. So remember our Latin, itis is like any sort of inflammatory process or like a problem, right? Think bronchioles, think uh, main stem bronchus. Bronch is lungs. Okay, so it's a inflammation of the tubes in the lungs. Okay, all right. So bronchitis. This can be caused by an increase of mucus and of inflammation. Okay, so you can have both of these things going on at the same time. So it's not autoimmune, but it's almost like an immune response. So in order to your lungs kind of think there's a problem, so it's causing inflammation. So like an inflammatory response within your lungs around the bronchioles. Um, and then there's also an increase of mucus, right? Like if it's let's pretend for a second it's autoimmune, which it's not entirely. Um, if there's an inflammation, it means the body is sending extra cells and increasing the blood flow to that specific area. So that's all well and good when you have inflammation of I don't know, your finger, right? Because it can become inflamed, it can get a little bit bigger. But when we're talking about a space where the pressure differentiation or the pressure gradient is a difference of 8 millimeters of mercury, any small amount of inflammation is like really bad. Okay. It's noticeable very quickly when your lungs are inflamed. Okay. So you have this bronchitis, bronchitis, I don't know. There's a bronchitis response that's going on. That's a good way to put it. But then there's also emphysema going on as well. Okay, so emphysema is really just destruction of the air spaces. Okay, so you can kind of see if this is like an alveoli right here, like this whole thing. You can kind of see where in the emphysema alveoli, you're just kind of breaking down those gaps, right? So think like cardiac hypertrophy, right? Like they're getting stretched out, the walls are kind of breaking, and you're ending up with like a large stretched out space that can't really mediate gas exchange. Okay, this is just like straight damage. Okay, and what happens with that is in a smaller space, you can control that pressure gradient a lot better, right? As opposed to a larger space. Think about like if you were to take a balloon and kind of fill it up within your hands, if you just squeeze it, like you can push all the air out, right? So you have it full, you can squeeze it, and all the air can just be pushed out, right? That's what's supposed to be happening in these alveoli. Okay, you're supposed to be able to control that pressure a lot stronger, as opposed to if you take that same balloon and you blow it all the way up, and you put the same amount of squeezing pressure, like if you're doing this, you put the same amount of squeezing pressure, you're not really changing the pressure within that airspace, right? If you have all these gaps and breakdown of the alveolar walls, right? So if that's happening, um, you're not going to be able to kind of compress, put pressure on that O2 to push it out into the tissues in the capillaries, right? Um, so two different things are happening right here. But the main takeaway of this is you're not exchanging oxygen as well because of both of these things. So you're getting less oxygen in, and you're not as able to exchange. You're not able to exchange it as at um, an ideal rate like you should be. Okay, so two different things are happening, caused by a lot of different things. But you're narrowing the airspace and you're widening the gas exchange space. So that's bad. Okay. Any questions about COPD? It's hard to breathe on COPD, not because you can, like your diaphragm's not moving. It's just you're short of breath. You're not exchanging oxygen. So your body is, because your oxygenation levels are lower, you're overcompensating, right? Like your body's telling your lungs, hey, work harder. I need more oxygen. And your lungs are working harder, but they're not as efficient. So they're not able to exchange that oxygen. Okay. So generally treatment for this, like Homo 2, really be on O2 for a long time, pretty much forever. Steroids help, stuff like that. So that's COPD. Any questions? Okay, seeing none, I'll move on. Asthma. Asthma bad. Okay, asthma not good. All right, so if this is, and we kind of talked about this a little bit, so I'll keep this one brief. But if this is a normal cell, um, you can see these goblet cells right here, right? These are what secrete the mucus. So the mucus builds up here, and then it goes, achoo, and then there's like a mucus layer that's lining the inside of your lungs. That's a good thing, right? It helps with contractility. It helps exchange the gas, right? It's easier to exchange gas in a liquid than a solid. So it's a good thing to have some mucus, okay? It's a bad thing to have a lot of mucus. So you have, in asthma, you have more goblet cells, um, and they are producing more mucus, right? And eosinophil infiltrates, right? So it's, again, almost kind of like an autoimmune disorder, okay? So you can see down here in the lamina propria, yeah, in the lamina propria, which is like this bottom layer right here, you can see that there's not a whole lot going on as far as immune stuff. Down here, there's a lot of immune stuff going on. Okay, so we've got swelling in the lamina propria. Um, we've got more uh, eosinophils and more white blood cells and lymphatic lymphocytes. Lymphocytes. That's what I'm looking for. Okay, and then so that's producing a thickened cell wall, right? Like there's a couple layers, and it's a thickened layer, and because those goblet cells are producing more mucus, it's another thickened layer. So you're not getting a very good gas exchange, and there's less surface area. Okay, so during an asthma attack, you kind of reach that peak. You kind of go over the top, and that could be caused by like an inflammatory response. It could be caused by weather or like a reaction to something. So, like if you have an asthmatic who's especially prone to asthma attacks when they, smell cigarette smoke or something like that, especially like in kids, right? So that'll trigger an immune response, which is pushing this layer even larger, right? So your immune layer is out here. You're shrinking up that airspace, right? And that will trigger the asthma attack, right? Because you already have a reduced airspace. So when we're talking pressure numbers, a difference of 8 millimeters of mercury, if that difference shrinks to 6 millimeters of mercury, then we've got a problem. Okay, it needs to work within very, very tight confines. Okay. Any questions about asthma? One thing with asthma, why don't I do this? I ask questions for questions and then just keep going. One thing with asthma is you see like this normal area right here, and you see this up here. This is all smooth muscle, remember, right? So if you have an asthma attack and you have what's called bronchospasm, these muscles can just contract, like they're just freaking out and they just squeeze, right? And then you can't get any air down past, like, say here, right? So, like, this whole lung is out of commission. Like, this whole side is out of commission. So, like, can't exchange air to begin with, and you're bronchospasming right there, so that'll close off, right? And you're just in a bad place. Um, so yeah, so that's why it's really important for like people with asthma to avoid triggers because it can cause asthma attack. Anybody have asthma? Going down, guys. Anybody had asthma and they grew out of it? Do you know why people grow out of asthma? Because they get bigger. That's like most of the answer. It's not a very complicated answer. All right. Chronic bronchitis. You got bronchitis. All right, so inflammation of the lining of the bronchial tubes, um, which carry air to and from the lungs. So this isn't a problem with if this is within the alveoli, and this one's within the alveoli. This is just straight up bronchioles. Okay, so bronchial tissue right here, these little stems of the tree limbs, right? And that could be caused by like a mucus plug or inflammation around here or bronchospasm, like the muscle squeezing. So all of those can cause bronchitis. Bronchitis is a catch-all for your bronchuses are bad. Okay. Um, it's which is why it's like really frustrating when you go to the urgent care and they're like, "You have bronchitis." And you're like, "Okay, cool. What else do I have?" And they're like, "I don't know, man. All I hear is bronchitis," because you can hear that airway narrowing, and you can just tell like it's something wrong with the bronchioles at that point, right? So yeah, so inflammation, mucus, kind of like asthma, but not like asthma's got a little bit of like a genetic component to it, a little bit of like an environmental component to it. Bronchitis is more like autoimmunity. So, but bronchitis, bad lungs. Cool. Any questions so far? Anything? No? Okay. That's fine. All right, emphysema. All right, let's do this. We're going to stop with this lecture for just a second, and I'm going to introduce you guys to something cool. Okay? All right, this is a website called teamrats.com. I had a professor in grad school, and she was like, "Hey, I work at Johns Hopkins. I have a ton of information. I'm gonna put it on the internet." And so she started this website called teamrats.com. So if you want to know everything about radiology, short of like going to medical school and learning it, it's all on here. So if you want to learn anything radiology related, you can probably learn it from here. What I'm going to do is I'm going to show you how to read a chest radiograph. Okay, so you go here, transitions to the ward, basic principles, and CXR intros. Okay. Um, there's some video lectures from her too, which are like pretty good. I like Dr. She's nice. Um, but yeah, I'm gonna kind of show you. There is a PowerPoint on here somewhere. I couldn't pull it up. Oh, lecture slides. What's that? No, that's not. Okay. So yeah, so there is it's here actually. It's not. I'm gonna stop doing this. Okay. All right. So this is not a comprehensive overview of how to read imaging. I just want to introduce you to the basics. So don't go around reading people's x-rays and saying you got bronchitis because you're probably wrong. You can't see bronchitis on x-ray as well. Okay, so I'm going to skip all of the stuff right here. So this is like the history of radiation and science and a whole bunch of physics, what we use it for, what is a CT, all of this stuff is on here. Um, how radiation moves through different tissues, right? There's some quizzes and stuff. You can play around with this on your own. I have been traumatized enough by this material, and I'm not going to, but have fun. There's MRIs, when you should use MRIs, why you should use them. And then if you get all the way down here, oh, big ultrasounds. If you get all the way down here, we get to chest x-rays, okay? So, yeah, just fill in it starts off somewhere. Okay, here's how to evaluate a chest film, okay? Uh, there is a systematic process that doctors use, radiologists use, whenever they're looking at chest radiographs, okay? So there's an amount. A, B, C, D, E, F, sometimes F, and G. Okay? So airway. And I'm going to blast through some of these and then go straight to lungs. Okay? Because that's really all that matters. But I want you to know what you're looking at when it comes to lungs. All right? So airway. So you're looking for the trachea, right? And you can see it right here, kind of. Okay? And it branches and it branches. Okay? So airway. You're going to look at that. Okay. B is bones. So you're looking at the spinous process. These are bad bones. They're crooked. Okay. Um, yeah, so you can see all the bones. You can see ribs, see if they're broken, that kind of stuff. All right. C is cardiovascular. So as you can see the heart on a chest X-ray, right? So if this is the whole heart, that's the apex. This is the aorta. Reaches off the aorta, right? All right. This is somebody with CHF, a big heart. Okay, big heart. All right. D is diaphragm. So on here, right, you can kind of see the diaphragm, this like thick and white portion. One thing that you, just so you know what you're looking at, okay? Everything that's black is air or lead, like things that there's nothing to bounce off of. Okay, so lead traps the particles; they don't bounce. Right, that's why it's black. Okay, everything that, and then from there you get a varying degree of like it's grayscale, and it's like all the way up to white. So if you've got something that it can't bounce off of, it'll be white, right? Like here, like you see these like really dark things. Sometimes like bone is going to be like pretty obvious because especially if it's like stacked on top, it's like bones like this. It'll be like more white. You can see like here, it's just not. That's not what your ribs look like, but they're just at an angle, right? So you can see that. And then sometimes you see these little markers like here or like that R. Somebody put like a little R, they slapped it down on the patient, right? Okay, so everything is white. The brighter it gets, the less it's moving through, right? So, so it's not bouncing off. A couple of things. This right here, this little, this is if this is air, right? This black part is air. That's the lung. Okay. All right, so that's your right lung, that's your left lung right there. Here's a good view of the trachea. You can see this black right here. That's the trachea, okay? Because there's air in it, so you can see through it, right? So you can see that trachea right there, and then the branches right there, okay? But there's also stuff in front of it too, so you can't really see it super great, but you can kind of see it, okay? So trachea, right lung, left lung, okay? And then if this is the lung apices, right at the top of the lung, you can kind of see the fissures a little bit here and here, kind of there. And then maybe like right there. There's another thing in here that if you play around with this, you'll see. And the rule is 2 views is 1 view and 1 view is no views. Okay, so if you really want to see fissures, you do the lateral view. Okay. This bottom part, this is where the lung like lines up with the diaphragm, right? So they're butted up next to each other, which makes sense because the diaphragm acts directly on the lungs. And then this little thing right here, this is called the costophrenic angle. Okay, so the costophrenic angle, because it's an angle. Okay. Phrenic, the phrenic artery or the phrenic nerve controls the diaphragm sometimes a little bit, mostly. Okay. So phrenic and then costo also obviously is ribs, costal. Okay. So that's just a couple things to know. Okay. So airway, bones, cardiovascular system, we can see the heart, diaphragm. Diaphragm's right here. Oh, another thing, real quick. Muscle shows up on a chest x-ray or like a regular x-ray. You can kind of differentiate a little bit of muscle on it. Why is that? Anybody want to take a guess? It's a fun fact. I'll give you a hint. It's got to do with the same reason bones show up on X-ray. All right, not enough hint. That's fine. Calcium. Calcium's in muscles, right? We need calcium for muscles to move. Calcium for muscles to move, right? So calcium is a heavy element, right? And it's hard to, there you go. Yeah, way to guess after I already gave the answer. It's a heavy element, so it's hard for that radiation to bounce off of or like pass through directly. It's not like air, it can't just shoot all the way through it. So right here, you can see this diaphragm. It's mostly muscle, and it's a very active muscle. It moves 100% of the time. So lots of calcium, right? This is a very um, is a big buff muscle. Okay, so there's lots of calcium down here. Same thing with the heart. That's why you can kind of see the heart really well because there's a lot of calcium in there. Okay, so taking X-rays of like people with like big giant pecs and stuff, difficult because they're muscular, right? All right, so diaphragm. The diaphragm, think of it like a parachute almost. Like it's got that kind of shape. And what that does is it'll cause like this, the lungs to kind of form around it. And you have these angles, right? So you should be able to see pretty sharp margins. Margin is like the outside of the lungs, okay? Right, diaphragm. So you can see here, like this one, the diaphragm is up here, right? Because it's thick. So we'll get to the fusions in a second, but that's what's happening right here is it elevates the right heavy diaphragm. Okay, so you can see how like it messes with that angle, and they're not even. Another thing about lungs and chest X-rays is the lungs are supposed to be like pretty even, like this. Okay, they're supposed to take up the same amount of space for the most part. Cool. All right, effusions. So E is effusions. So an effusion is a fancy word for a collection of fluid in the pleural space. Okay, you can have pulmonary effusions. You can have effusions in the knee, right? Like a joint space with too much fluid in it is called an effused knee or joint. Um, so there should be a little bit of fluid, right? Like 2 to 10 cc's of fluid in the lungs. But if it starts building up, you'll end up with these like weird looking spaces that are like dark and like full of water. Like you can kind of look at this and be like, that has a lot of water in it. Okay. Um, so you're looking for like this. The other thing too is there's a lot of mucus like on the bronchioles and stuff. So like you should be able to make out like the different bronchial segments. You should not be able to see like a bronchial segment and then like a cloud or something like that. It should be just enough that you can see it. If it's too much, it's an infusion. Okay. Um, so you don't need to know transitive and exudative, but basically, uh, transidative is like backup of fluid from the heart into the lungs, right? Like interstitial fluid or something like that. And then it's due to oncotic pressure. And then exudative infusions are things like there's blood or there's possible lymphatic stuff in the lungs. Okay, so think asthmatic. If you look at a lung, it's going to be actually let's see, find an asthma lung. Let's do it. Uh, yeah, this isn't like an amazing example. Don't judge me, but it's close as I can get. Here you go. So you see how it's like really opaque. You can't really tell, like you can tell where the bronchial segments are, but there's not like clean black air. There seems to be like a little bit of grayness everywhere, right? That's kind of what we're looking at right here. Um, as opposed to like here, it should be like pretty black and crisp. Okay. So this is like effused, right? There's extra fluid in the lungs. Okay. Um, all right. So that's effusions. Okay. And like I said, they can be due to fluid in the lungs, like heart block, and like a problem like a backflow into the lungs, or they can be due to mucus and inflammation, so like think pneumonia or some sort of pulmonary disease. Another word for effusions, especially in the lungs, is like infiltrates. So you might see that. Okay. So the next one is F. Oh, this is another good point. You can spot the pleural effusions by checking the angle, that costophrenic angle. So if it's rounded, if it's not sharp like this, you can be like, oh, okay, that's a right lung effusion. Okay, right pleural effusion. Okay. So yeah. So fields. You should be able to trace it. So like the lung fields themselves should be traceable. Like you could see the different bronchioles, right? Okay, same there, like there. This might be a lymph node, but yeah, you can kind of trace them throughout there. Okay, the small f, the sometimes f is foreign bodies. Sometimes you're looking for an f and you find one. Sometimes you are not looking for an FP51, which is bad. Okay, but there's other like foreign body things, so like things that should not be there, right? So, this person is being given a stent. You can see it right there, and a central line, which would be like over here, probably. Yeah, so this goes into the heart, right? This little tube right there. So there's two foreign bodies there. Sometimes foreign bodies are other stuff, like there was a picture on here somewhere else, but it was, let's see, this one. It wasn't this one, but I'm going to show it to you anyway because it's kind of what I'm looking at. But sometimes a foreign body looks like that. And you're like, that's not supposed to be there. So same thing with like lung X-rays. You can use the X-rays to look at things in the abdomen too, right? And a lot of other stuff. So, um, yeah. So foreign bodies. This is why when people show up to the ER and they're like, I don't know what happened. Something just got stuck in me, and you're like, okay, let's look. And then you do an X-ray, and you're like, yeah, you shoved something somewhere that it wasn't supposed to be. It's very obvious, right? Like you can see, like that's not good. This is probably on this person's stomach. But costophrenic angle, they're aerating well, so that's good. Good for them. The diaphragm is pretty good. Ooh, it's in the liver a little bit too. That's good. All right. So anyway, that's foreign bodies. Those are fun. Just look up like foreign body chest X-rays. You'll find a lot of really cool stuff. All right. The next thing is I don't know, but this is a good example of like an effusion, right? So like this is an effusion, and generally speaking, if it's like water, it'll settle to the bottom, right, because of gravity. But if it's like an infectious process and it's isolated to like one area of the lung, you can tell, right? So you can look at this and you can go, okay, this person has probably pneumonia of the left lower lobe, okay? And like they said, lateral image would best confirm location because you can kind of take here, turn sideways, take here, and then you can just pinpoint where the X marks the spot, right? G, gastric bubble, not as important. It's to see if you have air in the stomach. So don't worry too much about that. All right, so that's A, B, C, D, E, F, G. Okay. This is a lateral view, so you can see like the anterior mediastinum, the middle mediastinum, the posterior mediastinum. So you can see the lungs are like here, right? That's really sharp. Okay, and that's like pretty much it on imaging. Okay. So hopefully that helps, and we're not just looking at blobs anymore, because that's the point of anatomy is to take the things that look weird and um, uh, not think they look weird and make something out of them. Okay, so emphysema. Let's get back to the diseases. All right, so emphysema in a normal chest X-ray. Remember, we just looked at it. This X-ray is not a great X-ray. They've turned up the contrast on it, so it would be like the white parts are really white, the black parts are really black. Okay. Um, Emphysema though is remember those alveoli are kind of bursting apart and creating like larger spaces. There's more air hanging out in the lungs. So if you see a lung image like this, like ghostly, like Halloween spooky, you're not going to be able to make out like the bronchioles and stuff, right? Because the bronchioles aren't like they're not like sitting in front of the lungs and you can see them and then they go to the back. They're going into the middle of the lungs, right? So they're surrounded. If this is a lung that I'm holding and this is a bronchial, kind of turn it up, you can see that there's lung tissue on either side of it. Okay, so you should be able to see them, but if you can't, that means there's too much air in front of them or something. Okay. So this is just an example of like emphysema in the lungs. So you would these are fancy words you don't really need to know, but this is just know like hyperinflation, hyperlucency. So overinflated. You can see that like a normal lung, if this is the like the rib cage right here, like this is rib one, you can see that it's like all the way up here in this section, right? Like it's filling up that whole space as opposed to like having it a little close, right? It's also compressing the heart, right? Because your lungs are working harder. So you can't really see the heart as well on that one. It's small. Okay. Um, yeah, I mean, you're not going to have like vascularization as much because you kind of burst those cell I don't mean like cells, I mean like alveolar cells. To kind of damage those walls of the alveoli. So, yeah. All right. Any questions so far? Okay, great. I feel myself getting better. Sorry. So hopefully next week I won't sound like a weird robot. All right. Hey, there we go. Laryngitis. That's what I got going on right now. So I'm gonna go off on another tangent real quick. Laryngitis, inflammation of the voice box, of the larynx. Okay, so normal, inflamed, bad. So think like if you let air out of a balloon and then you pull it together, you're like closing off that space. The sides, the vocal cords can't vibrate very well when they're super inflamed. Okay, so you're closing off that balloon and it's going back. Sorry for my headphones. All right. So laryngeal inflammation. Um, Another tangent that I would like to go off of, just for fun things. I have pink eye right now, okay? Because my kid licked my face, and she had pink eye, so that's bad. Um, why do I have a little bit of laryngitis right now? You ever look at that? Why, if you get like a weird infection somewhere, you always end up with like a little laryngitis or like a cough at the end. If you get a cold, like it might be upper respiratory and then it kind of moves, you could feel it moving through your body. The reason for that is because there is something called the triangle of death. or danger triangle. But we're gonna call it death triangle because it sounds crazy. Triangle of danger face. Here we go. Imaging. All right, so this section of your face is the danger triangle. Why is it the danger triangle? Well, I'm glad you asked. The reason is, so let's start with your eyes, because they're not really in the danger triangle, but kind of. They're on top of the danger triangle. If you look here, that's a good view. You can see, so if you have your eyes, right, your tear ducts they drain into your nasal cavity, okay? So I have an infection in my eye. It's draining into my nasal cavity, causing inflammation in my nose, right? So my nose is creating an inflammatory response, and I'm stuffed up here, okay? So that vasculature right here is all interconnected, okay? And you can see there's ways for it to get down into your mouth, right? And then from your mouth, it's just a hop, skip, and a jump into your pharynx, right? So if this is all connected, if you get something in the vasculature in here, it's real easy for it to move here. So you're going to get an inflamed pharynx, or it might come through the nasal cavity and drain down with all that snot and goop and cause inflammation right here. And then that inflammation will cause inflammation right here. And then that inflammation will cause inflammation right here. So it's all like this horrible area that is just all connected and breeds infestations. And there's a lot of like nooks and crannies and caverns all up in this area. So there's a lot of places for like infections to hide out, right? So if you have something that drains from your eye to your nose, it might hang out in here, build up a little bit, and then move its way down. Or as it's draining, it'll catch onto that epiglottis and get back down kind of into the lungs a little bit, right? So you're not like, not necessarily coughing up mucus, right? Like if you have a cold, you're not coughing up like all the mucus that was in your nose didn't drain into your lungs and you're like coughing it out now. What's happening is that infection is kind of like running away and it's getting down into your lungs. Your lungs are causing their own mucus, you're coughing that out, right? So because we have goblet cells that are creating mucus, okay? So this is the danger triangle. So an infection that starts here could end up like here, and it can get real bad real quick. Okay, that's why all of this. It seems like you might get like a sore throat and a nose issue, like all this. And then there's people on TikTok who like make it sound like you're gonna die if you ever get a disease, but you're not. It's not always. It's just that it's all connected. Okay. And then the other point of this is there's also vasculature right here too. So your ophthalmic veins come into here, right? So if you're draining blood that's infected into here, you get all up in your brain. That's not good. So you go into the cavernous sinus, the petral sinus, into the jugular, all that fun stuff. All right, so that's the danger triangle. What does that have to do with laryngitis? Well, those bugs can move the larynx and it'll inflame it. And that's really all you need to know about laryngitis. Other causes of laryngitis, overuse, it's a muscle, right? So if you're overusing it too much, you're going to get sore. Irritation, if you cough, if you aspirate on something, if you choke on something and it goes down into your lungs and comes back up, it's going to slap right by these things, right? So it's going to and then fall down, and then as it's going out, it's like, get out of my way, leave. So, or infection, right? So that's your laryngitis. All right, cystic fibrosis. Okay, this is a genetic disorder. So it's not like really asthma or COPD or anything like that, but it does operate kind of in the same way. So cystic fibrosis is overproduction of mucus in airways. Okay, so way too much mucus going on, really hard to breathe. Okay, so you can treat that with like steroids and stuff like that. But it's genetic, so they're just always going to do that. The only cure for cystic fibrosis is like lung transplantation, and like that's really it. Okay, so cystic fibrosis is bad. Fibrosis eventually, like this mucus will just kind of harden off, and you'll just end up with like areas of the lung that just don't work anymore because they just it's just mucus and hard. Like it's years of mucus that's just like thickened up and gets hard. So it's really not a fun thing, right? Infant respiratory distress syndrome. This is not like super well known. Think like SIDS or something like that too, along those lines. But you can tell from like fast shallow breathing, labored breathing, or hypoxia. These are things that you're going to pick up like immediately after a baby's born. You're going to be like, this infant has respiratory distress syndrome. So um, sometimes underdevelopment could cause that. Sometimes it's genetic or whatever. So don't really know like a whole bunch. All right. Pneumothorax. That's bad. So if this is a normal lung, this is a pneumothorax. So pneumo, lung, thorax, chest, your lung, and your chest. I'm just kidding. That's not chest. Um, it's a collapsed lung. Is basically what a pneumothorax is. Okay, so um, you can tell like this one, and the way you can kind of tell if you're looking at imaging somebody has a pneumothorax, one of their lungs generally is going to look fine, right? Like you'll see it. This person's got like an effusion right here, but not really that bad, right? So you'll see that. And there's like well defined, there's your claustrophobic angle, right? And then this side, you're like, that's really small. That shouldn't be like that, right? Because um, you are getting that because something is pushing up against that lung, right? So something in the thoracic cavity is pushing up against it, causing it to collapse. Okay. Um, so this is just like a breakdown of what you might see on an X-ray. So no vascular markings on the right, so you can't really see like the vasculature and like the pulmonary artery, right? No shift of mediastinum to the left, so you won't really be able to tell like where the heart is and stuff. There's deep sulcus, so like it's pushing, right? Like you can tell that like this is half a lung right here. Okay. Increased haziness on the left, so diversion of the entire cardiac output. So your heart is diverting all of the blood that it's pumping to the lungs. It's diverting it to the other lung, or it's diverting it to like different areas that are collapsed. Okay. You can use the smooth muscle cells, right? You can control that. You can't control it, but something can. And that somebody up in your brain, some little alien is going, oh crap, that one's collapsed. Let's pull this and push this over here, and we'll be able to pump all the blood over here. So let's squeeze off all the lungs over here, and then open it up on this side, right? So um, you might be able to see a small amount of fluid near the costophrenic angle, right? Because think of gravity, so it'll end up at the bottom of the chest, right? Um, so you might see like you see how this isn't. It's like black and then gray and then white. It shouldn't be like it's grayscale, right? There should be more of a distinctive black than white. Okay. Atelectasis. So atelectasis is a fancy word, and I'm gonna give you the definition of it. Uh, Atelectasis is a partial or complete collapse of the lung that reduces and prevents gas exchange. Okay, so pneumothorax, basically. So you can see right here that this left lung is a little more normal, right, and then the right one's just like gone, right? So it's collapsed somewhere. So all of the air is being shunted into here. Okay. Um, Yeah, not much else to say on that. They're kind of the same thing, but not really. All right, pleurisy. So remember the pleural spacing, the pleural linings, right? We learned that a little bit in embryology. So they're different cells, right, that stick together, come from different areas. So the lung lining, so the pleura, so the visceral pleura or the parietal pleura, that is inflamed. Okay, so you're kind of you're gonna press it on the whole lung, and it's all inflamed. So you're just creating a smaller space. Um, so that's really what's happening right here. It'll cause like painful breathing, worse with deep breath, right? Because you're inflating it more. Um, a couple things. Have um, you don't have nerves, like pain nerves within your lung. Okay. So like if I were to take um I don't know, if I were to take something sharp and poke you from the inside out, that's a weird analogy, but like starting here in space and then poking your lungs, you wouldn't be able to feel that. But you have nerves like within the pleura, right? And like you also have nerves in your rib cage too. So you'll be able to kind of feel like it'll hurt. It'll feel like a chest pain, but you're like, ow, but it's not so much. It's not like pain. It's not lung pain, if that makes sense. It's pleura pain, pleuritic pain. Okay. Sleep apnea. Who's got that? You suck at breathing at night. That there's a couple different reasons. It could be obstructive, like if you're obese, you have a smaller airway, or like a lot of fat around your airway. It could be because your nerves aren't firing as much, so you're like not breathing as much. Um, there's a couple of it could be like a disease thing. CPAP, continuous positive airway pressure, is CPAP and BiPAP are kind of the same thing. So it's just a positive airway pressure. So what you're doing is you're taking the atmospheric pressure, you're increasing it, right? So that that gas exchange will happen at a different pressure differential, pressure gradient. Differential. A different pressure gradient. So you're increasing that ambient pressure, pushing more oxygen into the lungs. Okay. Saved my life. Love CPAP. Tuberculosis. This is bad. Tuberculosis is an infection in the lungs, but you can see effusions right all throughout down here. So this is normal. You can see it's like effusions all throughout the lungs. This is why it's really hard to differentiate. Like if somebody comes in and they're say 60 and they have a history of like heart failure, but they're also sick. You know, it's hard to be like, hey, you have pneumonia and you need antibiotics, as opposed to, oh, it's just your heart failure acting up, right? You can't really differentiate that on just a chest X-ray alone, right? So if you go to like urgent care or something that maybe that's the only thing they have, it's really hard to like pin that down, okay? Because fluid's fluid. It just looks like this on the chest X-ray. So tuberculosis looks just like fluid in the lungs, basically, but it's a disease. It's bad. And this fluid could be bacterial infection, but it could be like from the tuberculosis bacteria, or it could also be um, like blood in the bronchus. Okay. One thing I'm going to turn you on to since I'm here, uh, there's a man. His name is John Green. He's an author, and he is a very outspoken critic of tuberculosis. Why? Because tuberculosis is curable. We cured it like 70 years ago, and people still deal with it. And it's like the largest disease killer in the entire world. And the only people that die of tuberculosis are people who can't access healthcare. And it's something we've already cured. Like, by the way, let me see how many people per year. It kills more people per year than the flu, which we can't cure, and we still put out vaccines for. Yes. Here. There you go. I agree with John Green on this. 1.3 million people died from tuberculosis worldwide, making it second only to COVID 19 in 2022. Okay. Um, like, what? We have a cure for it. We can cure it. So, write your senators and tell them we can cure tuberculosis and they need to work harder on that. Okay. Because, like, nobody should die from tuberculosis. It's like stupid cheap to cure this, and there's treatment for it. Okay. But it kills the most people in the world per year. All other years that didn't include COVID, tuberculosis was the number one killer of people in the world. It's awful. And we're doing nothing about it. So, tuberculosis, bad thing. Pneumonia. Pneumonia is a catch-all word, okay? Just because somebody has pneumonia doesn't mean you know what's causing the pneumonia, okay? Um, so let's see, this is a cartoon. So there's different symptoms of pneumonia. There's different sounds that you'll hear when you're like listening for pneumonia. So you'll hear different breath sounds. Um, um, it's an acute infection usually. It can be caused, it can be acquired like in the community, or it can be hospital acquired pneumonia. So a big thing about pneumonia is when you go on a ventilator, for instance. So like say you are driving home tonight, and you get a big car accident, okay? You go on a ventilator. Um, there's like a clock, right, where they go, okay, we got to get this person off the ventilator before 48 hours because the risk of getting hospital acquired pneumonia on a ventilator is like stupid high after 48 hours. It's like almost guaranteed. If you're on a ventilator for an extended period of time, you're gonna get it. Okay. Um, I think 10 days is like the like 100% chance you're getting pneumonia within 10 days. But yeah, it's bad. It's just a bacterial infection. The most common is strep. So strep throat, right? Streptococcus pneumonia. Strep, streptococcus is a bunch of different bacteria. I don't know if you guys have taken micro yet, but just because something says strep doesn't mean it's like one strep. There's a whole bunch of them. Okay. So and just like that, there's a whole bunch of things that cause pneumonia too. It's not just strep. This is just the most common one. Okay. So you can see right here, the thing that differentiates like diffusion versus or an effusion versus pneumonia is an effusion generally, um, well, you want to consider symptoms, right? So like if somebody is like, oh, I haven't been sick, I just have CHF, like and there's like fluid in the lungs and infusion, like okay, that could cause it. But something like this, especially these like mid-lobular things right here, right? Gravity would have already pushed that down if it was water. But it's an active infection here, right? So there's an immune response here that's causing an increased area of opacity. Okay, so you could look at something like this and be like, that's probably pneumonia. Okay, so note the indistinct borders. So like it's spreading, right? Like it doesn't have like sharp cutout. It's not like we put up a fence around it and like you stay here. It's spreading, right? So you can see the indistinct borders. You can't really see the bronchioles like quite as well. And air bronchogram, so in the right heart border. Yeah, so this is the right heart border. This is the bronchograms. Okay, cool. Point of fusion. We kind of talked about this. We did talk about this. So it's a homogeneous density, um, loss of cardiophrenic angle, uh, or costophrenic angle, either one. Diaphragmatic and right cardiac silhouette. So like you can't really tell where the heart is because there's a lot of fluid in the way. Okay, that's pretty much it. All right, lung cancer. Don't smoke. Some of you smoke. Don't do it. your lungs will look like this when it's bad. Lung cancer. So if you put crap in your lungs, right, it's just another place for things to take hold. Okay, so if it's carcinogens and they're sitting in your lungs because you can't breathe them out because they're little micromolecules, and they just settle, they just stay. They're going to create chemistry with your cells, right? And when they create chemistry and get into your cells and they mess around with your DNA, they'll create cancerous issues. Okay? Cancer is another catch-all word um, for cells that are duplicating too much or not dying fast enough. That's like literally it. So when somebody tells you that we already have a cure for cancer, and I get it, I'm the first person that you would expect that kind of thing from. We don't have a cure for cancer because they're all very, very specific. Every cancer, there's a couple general things that operate the same, but for the most part, it's one type of cell doing one type of thing way too much, and that's what causes tumors. Okay, so it's really hard to nail down like a general cancer vaccine. You can't really do that. So carcinogens cause cancer. There's carcinogens in smoke. If you smoke, you'll die of cancer. Okay, so don't smoke. That's all I got for you. That was fun. Any questions? I like application of anatomy. It's fun. Um, I'm gonna cancel lab tonight. One, because I feel like death, and two, because I've been like going back and forth. I don't want to move on to the next thing before we have that midterm. So if you guys are on here, you're more than welcome to log off 10 minutes earlier than the announcement I'm about to post. And yeah, you do have a ton of lab homework, but it's not due until next week, so don't worry about that. Next week, I don't know. It's due sometime. But yeah, don't like catch up on the one ones. 13, 20. Yeah, you got 2 weeks. Um, catch up on the lung one. Like, take your midterm at the beginning of the week and then do your lung homework for that. Next week during lab, we'll do review sessions. So anything that you guys have questions for up until this point, not respiratory, no lung stuff on the midterm. Anything that you guys have questions about, bring it to the table. Everything is on the table. It's the human body. Everything is up for discussion. Okay. Um, but no, here I sent out a study guide. Respiratory is not on the midterm. Everything before respiratory is on the midterm. I sent out a study guide, kind of. It's not my best work, but it's what you get this week. Um, just because it's on the study guide doesn't mean it's going to be on the midterm necessarily. And just because it's on the midterm doesn't mean I had to put it on the study guide. So Top Hat's going to be a good resource. And I don't mean that as like a threat. I'm just like, it's the human body, everything's on the table. You should know everything we've talked about at this point, right? But most of it is up there. The exam for lab is not on Top Hat. It's going to be on Blackboard, just like the lecture exams. It'll be, I don't even know how to do that, so I'm sorry. It's going to be on Blackboard. It'll be mostly multiple choice. And by that, I mean like 95% multiple choice. The easiest labeling models. Yeah, well, the other thing too, and this is another thing I'm going to get at, is everything that's labeling on the exam is going to be straight up from all of the lab images. And I'm going to add a disclaimer. That's what Dr. K told me, and that's what I'm going with. So if there's if there's something that's labeling a model, it's a picture that you have access to right now and can go look at that's already labeled and you can study off of. Okay. Which also apparently match the ones that are available for you guys to go look at somewhere. I think there's like a library or something. I don't know. Email the anatomy tutor and be like, hey, look, models to look at. So yeah, apparently all of those labeling pictures, the models on the lab images and models, are all pictures of things that are in the lab. Okay. So if it's labeled on the midterm, you have seen that picture before. I'm not pulling any pictures off the Mr. Google and giving you like brand new stuff that you've never seen before. Um, some of the stuff you're gonna be like, I've never seen that blob before, but you have. It's histology. They're all blobs. Figure out what the blobs mean. You'll be fine. I, out of the niceness of my heart, because I'm a kind person, it did my very, very best to, if you need to, um, if it's not multiple choice, I changed the question to give you options, if that makes sense. So if it's like, if the question initially said, give me the name of the labeled item, and it was um, the aorta or something like that. I changed it to is the labeled or item the aorta, the pulmonary artery, whatever. I give you options. So it's still an essay question technically, but I gave you multiple choice options. Okay, so don't come at me. I was so nice to you. Um, so don't worry too much. There now, I will say there was a couple of them that I was like, I can't really do that without giving the answer away. So there's going to be a couple that you're going to have to like try. But for the most part, it's going to be mostly multiple choice. It's I have 42 questions so far, so that was what I was able to pull from some of the other exams. So I'm going to write a couple new questions, same style though, and they're probably none of them are going to be like labeling or anything because I don't want to like pull images and crop and do all that fun stuff. So that's the breakdown of the lab exam. Next week we'll do some review. Come with questions for lab review, and then we'll move on. Okay. Okay. I love you, puppy kiss. I can't say that. Okay. Um, any questions? I know we're like moving on in lecture. Um, I have to. I can't like just take 3 weeks off. So I forgot to do a review session for the first test. So to be honest, didn't think about it. So that was part of the reason the pacing sucked. And also, I don't know when I'm supposed to lecture on everything. So I'm going 1 month at a time, folks. So exam 3 will be module 3. So, and that'll be the date that I gave you for it. So we'll have a lab midterm, and then I think a week off, and then not a week off, but a week without like an exam, and then a lecture exam. Okay. And that'll be respiratory and digestive. Okay. Respiratory and digestive is a lot of stuff. Okay. So pay attention, take your notes, watch videos and stuff. You'll be just fine. Okay. If you're in the live class or if you're keeping up with lectures, I will say the one thing that I've noticed as far as like trending for grades, like almost everyone who attends lecture and like watches the lecture on the other class like ahead of time does really well. And the people who do the poorest are like, because it's YouTube, I can see if uh, Mama Thomas Smith watched the video the day before the test, um, and I can tell whenever you guys log into Blackboard and take the test. So if that happens, just know you should get on it a little more. And if you feel like you're doing everything you need to do to pass this class, you're not doing a very good job, please let me know. I haven't seen really very many people that are like really struggling. But send me an email. I don't have office hours, but I can meet with people, like set up office hours on WebEx and stuff. So let me know what you guys need. I know it's kind of a poop show. So, yeah, I'm not trying to like come in here and be like, I don't know what I'm doing and I'm a jerk. No. So, um, yeah, that's all I got for you guys. Okay, any other questions? Any questions? Okay, enjoy your night off. Um, and I'm gonna go collapse into the sun. Have fun. See you guys on a much healthier week. Okay, bye.